Hi, I'm Dr. Reshma Mahtani, Associate Professor of Medicine at the Sylvester Cancer Center, University of Miami. Today we'll be discussing optimizing therapy in HER2-positive breast cancer. We'll be discussing HER2-positive breast cancer in the curative setting as well as the metastatic setting. And here's some information that summarizes some of the things that we're going to be talking about today. We know that trastuzumab has markedly improved outcomes for patients with early stage HER2-positive breast cancer during the last decade. And we also know that those gains are associated with improvements when accurate testing is done. So we'll talk a bit about testing and ASCO-CAP guidelines. We'll also talk about de-escalation strategies, including the use of anthracyclines, whether we need a full year of trastuzumab, and can we really use less intensive chemotherapy in certain settings. And then we'll also turn to when is more better. We have, fortunately, multiple new approved therapies in the early stage setting, including neratinib in the extended adjuvant setting, pertuzumab in the neoadjuvant and adjuvant setting, and then for patients with residual disease, TDM1. So we'll talk today a bit about how and when we should use these additional HER2-targeted agents. In the metastatic setting, we've made significant gains, but we still have work to do. There are unmet needs, including improving options for patients with CNS metastases. And we know that even with the target identified and targeted drugs available, resistance inevitably occurs. So sequencing newly approved and existing therapies such as tucatinib, trastuzumab deruxtecan, and neratinib in the metastatic setting will also be discussed. And then we'll close with future directions. This slide illustrates that the prognosis of HER2-positive disease is poor without trastuzumab. And younger physicians, fellows, and residents sometimes forget this information because they're treating patients in the era of HER2-targeted treatments. But for those of us who remember what it was like to treat a patient in the era prior to trastuzumab, this information is something that we all remember. So this slide illustrates responses to chemo in locally advanced breast cancer by subtype. And you see the purple line, which illustrates outcomes for HER2-positive patients treated without trastuzumab. They do just as poorly as basal or triple-negative patients do. Fortunately, we've made a lot of progress in the adjuvant setting. Adjuvant trastuzumab improves disease-free and overall survival for patients with HER2-positive breast cancer. And this approval was based on studies shown here, including HERA, the joint analysis, and BCIRG, which is the only study that incorporated a non-anthracycline option for chemotherapy. You see the gains that we've made have been quite consistent and remarkable and have really improved outcomes for these patients. But we know that these gains and improvements are linked to accurate assessment of HER2 status. And based on signals in earlier trastuzumab trials, most notably B31, patients with HER2 low tumors by central testing derived similar benefit than those, as those confirmed to be HER2 positive. So B47 tested this in a randomized manner. Patients with HER2 1+ or 2+ FISH negative tumors did not gain any benefit, as shown here, from adding trastuzumab to standard adjuvant chemotherapy. So we certainly need to remember the importance of correctly identifying a HER2-positive patient so that we can get the drug to patients who benefit and not expose patients to toxicities of therapy when they don't benefit. As a reminder, ASCO-CAP updated guidelines in 2018 for HER2 testing. I won't go through all of the different questions and comments that were made in the guideline update. This slide nicely summarizes those. I'll draw your attention to questions 3 through 5, which really address the discordant patients with regards to IHC and FISH testing, and proposes a HER2 testing algorithm to address the recommended workup for these less common clinical scenarios, which account for approximately 5% of cases, but I would say 95% of the confusion when it comes to HER2 testing. Other comments were made, especially were with regards to alternative probe use. So again, this slide illustrates that algorithm that I mentioned addressing questions 3 through 5, looking at groups 2, 3, and 4 in patients that have a ratio greater than 2, copy number less than 4, or a ratio less than 2, a copy number over 6, or a copy number between 4 and 6. So the algorithm is clear in the further workup that's required to clarify these cases. Now moving on to early stage HER2 positive breast cancer treatment in the neoadjuvant and adjuvant setting, let's start by discussing what the intentions of administering neoadjuvant therapy are. Well, we can leverage neoadjuvant therapy in terms of surgical endpoints, and this information is quite intuitive. Patients understand this very well. We can take patients that were previously candidates for mastectomy and allow them to undergo breast conservation so we can improve operability. And we know that this does not come with any sacrifice in distant disease outcomes. We can also improve axillary management, and you see here the data that details the downstaging in the axilla that may be possible. And then of course, exposing patients less to the toxicities of axillary dissections, including lymphedema. But there's another outcome that we can, or another use of neoadjuvant therapy that is very important, which is it allows us to risk stratify. So we know that there is strong and consistent relationships identified between PCR and relapse and survival in multiple trials. And it's also important to note, however, that some patients who have a PCR still in fact relapse, while many who have residual disease don't relapse. So it's unclear if there's an additional biomarker that can help us identify who may benefit from additional therapy beyond the presence of residual disease. So who should be considered for preoperative systemic therapy? In breast cancer, we often advise patients who are triple negative with high risk features, high grade, lymph node positive, high tumor volume to breast ratio, and are younger. We also often consider neoadjuvant therapy. In patients with HER2 positive early breast cancer, the indications for trastuzumab in combination with pertuzumab are those patients that have a tumor greater than or equal to 2 centimeters or who have node positive disease. And that indication is really based on pivotal studies, including the open label phase 2 Neosphere study, in which trastuzumab and pertuzumab in combination was administered in one of 4 different randomized regimens. As seen here, patients then went on to surgery and then anthracycline-based therapy. The primary endpoint here was PCR. And the phase 2 Trifina study, where the primary endpoint was cardiac safety. Here you see the outcomes of the Neosphere trial. Again, this was a trial in which patients received 4 cycles of randomized neoadjuvant therapy, followed by surgery, 3 cycles of FEC and trastuzumab to complete a year. And in the intent to treat population, you see the improvement in PCR, or the higher PCR, as compared to arm A, trastuzumab docetaxel. Interestingly, there were patients, 18 out of 107, or 16.8% in the pertuzumab trastuzumab arm, that were able to achieve a PCR without chemotherapy at all. So this warrants further investigation. And then, as was expected, patients with ER/PR negative tumors had a higher PCR rate than those that were ER/PR positive. In the phase 2 Trifina cardiac safety study, we saw no new or unexpected cardiac events with the addition of pertuzumab. And all AEs were consistent with those observed in previous studies of pertuzumab, trastuzumab, and anthracycline-based chemo, either in combo or alone. We also know that achieving a PCR is prognostic, and that's illustrated here. This slide illustrates disease-free survival based on response to neoadjuvant HER2-directed therapy. So we know that this is prognostic, especially in ER-negative patients, and you see higher disease-free survivals across all of these studies for those patients that were able to achieve a PCR to neoadjuvant therapy. As far as de-escalating therapy, this is a common situation that comes up in the clinic, the use of anthracycline or non-anthracycline based regimens. And we know that in the pre-trastuzumab era, HER2 positive breast cancer benefited particularly from anthracyclines. But does this still matter in the era of HER2 targeted therapies? We know that anthracyclines have a small but real risk of cardiotoxicity, low numbers but not inconsequential, as illustrated here. And we also know that cardiac risk factors sometimes don't tell the entire story as far as who is going to have toxicity to anthracycline-based therapy. So what are our options? We have anthracycline or non-anthracycline-based therapy followed by a taxane and trastuzumab with or without pertuzumab. I'll be updating the bullet point shown here in terms of the benefit of pertuzumab in the adjuvant setting, especially with regards to ER-positive patients as we talk about affinity later in the presentation. The only trial that really compared a non-anthracycline and anthracycline, or not compared, but had both included, was BCIRG 006. In fact, this trial was not intended to compare an anthracycline versus a non-anthracycline-based regimen. But yet we do look at outcomes, and we do see that after 10.3 years of follow-up, the two trastuzumab arms showed a sustained and significant efficacy advantage over AC followed by a taxane without trastuzumab. However, the difference between the two trastuzumab arms was slight. And then you see a numerical advantage to the anthracycline. However, it came at a cost of a 5-fold increase in clinical congestive heart failure in the ACTH arm than in the TCH arm, and a higher risk of leukemia and sustained LVEF fraction decline greater than 10%. How about shortening the duration of trastuzumab? Well, this has been evaluated in multiple studies summarized here. The only trial where non-inferiority was demonstrated was the Persephone study. But this trial, there are several important caveats in terms of the patient population included in the trial. A good percentage of these patients received sequential instead of concurrent trastuzumab. High-risk patients didn't get dual targeted therapy, and not all patients received an anthracycline and taxane-based chemotherapy. So our summary of all these studies is that 1 year of trastuzumab remains the standard of care, but a shorter duration is better than nothing. As we turn to further de-escalation strategies, the APT trial, or the Tolaney regimen as we call it, is an important study that looked at patients with smaller, less than 3 centimeter node-negative HER2 positive tumors, and looked at the strategy of giving these patients adjuvant paclitaxel for 12 weeks, followed by, in combination with trastuzumab, followed by trastuzumab to complete the year. It's important to note in this trial that the majority of patients did have T1 tumors, T2 tumors, there were only 9, and ER positive and ER negative breakdown is also shown. Micrometastases were allowed. We see at 7 years a very good 7-year disease-free survival of 93.3%. There were only 4 distant recurrences, so this regimen is a very reasonable de-escalation strategy for patients with smaller node-negative HER2 positive tumors. Another trial that's important that's ongoing is the COMPASS trial, again looking at the strategy of de-escalation based on the patient's response to neoadjuvant therapy. So these are HER2 positive stage 2 or 3A patients that are newly diagnosed who then go on to receive a taxane in combination with trastuzumab and pertuzumab, and then go on to surgery. And if they have a PCR, no further chemo, they do complete the year of adjuvant Herceptin trastuzumab. And if they have residual disease, as now is the standard to receive TDM1 in that setting, patients receive either TDM1 or tucatinib, which we'll be talking about later as well. So this is an ongoing study and will be an important study to address a de-escalation strategy. Moving on to adjuvant treatment, we'll discuss now recent FDA approvals of neratinib, pertuzumab, and TDM1. And we know that we're building on the successes that we've had with trastuzumab by considering additional HER2 targeted therapy in the adjuvant setting. Neratinib was originally approved in the extended adjuvant setting in July of 2017 for patients who have received adjuvant trastuzumab-based therapy. Trastuzumab in combination with pertuzumab gained an approval in December 2017, used in combination with chemo as neoadjuvant treatment, as based on the data that we just reviewed, and also as adjuvant treatment based on the Affinity trial, which we'll go through in the next few minutes. And then very importantly, TDM1 in May of 2019 was approved as adjuvant therapy for patients who have residual invasive disease after neoadjuvant taxane and trastuzumab-based therapy. So we have these new agents, and the important thing is to recognize that there is information that can help us identify how we can apply these new data. All show significant improvements in DFS, but can be associated with increased toxicity. So this begs the question, how much benefit can be expected for an individual patient by adding pertuzumab to standard trastuzumab-based therapy, by utilizing TDM1 for patients with residual disease, or by extending HER2 targeted therapy for an additional year with neratinib. Let's start by reviewing the ExteNet 5-year update. This trial looked at neratinib versus placebo after adjuvant trastuzumab in HER2 positive early breast cancer. These were patients that had completed adjuvant trastuzumab. The majority within 1 year went on to receive neratinib versus placebo. The primary endpoint of IDFS at 2 years is shown here. And now we have the 5-year IDFS analysis, 90.2% versus 87.7%, favoring the use of neratinib. When we break it down based on hormone receptor status, we see a signal of a stronger benefit, or we see a signal of a benefit in ER positive patients versus ER negative patients. An explanation for this is really related to crosstalk between HER2 and ER, which is blocked by neratinib and thus leads to more comprehensive anti-tumor activity. In patients that have received only antibody therapy to this point, perhaps changing the treatment with a drug that has a different mechanism of action may be particularly important in these high-risk patients. When we look at patient subgroups even further in terms of ER positive patients that had received treatment less than 1 year from the last dose of trastuzumab, we see a delta of 5.1%, and even more impressive in these high-risk patients who had not achieved a PCR after neoadjuvant therapy. Now the delta increases to 7.4%. So this drug is clearly active, especially in patients with ER positive, HER2 positive disease. And the ExteNet data is useful in evaluating patients that may benefit. One of the issues that comes up quite a bit with neratinib is the issue with diarrhea. And in the ExteNet trial, there was not a mandatory use of antidiarrheal prophylaxis, and grade 3 diarrhea was quite high, about 40%. So the control trial was an open label study to characterize the incidence and severity of diarrhea in patients with early stage HER2 positive breast cancer treated with neratinib, but having proactive management of one of these antidiarrheal regimens alone or in combination. And in addition, there were 2 different strategies of dose escalation in combination with loperamide. And now with the use of antidiarrheal prophylaxis, we see a real decrease in treatment emergent diarrhea. Looking at grade 3 diarrhea in the neratinib dose escalation scheme 2, it's gotten all the way down to single digits. So clearly we are able to get this side effect under control with the use of antidiarrheal prophylaxis, and the median cumulative duration in days of diarrhea also has gone down significantly with prophylactic use. So we've learned how to manage this to a great degree. This slide illustrates neratinib-induced diarrhea over time in the 12 months of treatment. And you see again the progress that we've made in helping patients deal with this very bothersome side effect of diarrhea, with grade 3 diarrhea dropping significantly with the use of anti-diarrheal prophylaxis, and no grade 4 events occurred in the controlled trial. So moving on to the Affinity study, this was a randomized double-blind placebo-controlled phase 3 trial of looking at pertuzumab in combination with trastuzumab as adjuvant therapy for HER2 positive early breast cancer. Here, patients were node positive and could go on, or if they had node negative disease with high-risk features, they were allowed to be enrolled. And we heard at ASCO 2017, 2.5 years from the, we heard primary analysis of this trial. Now we have a median follow-up of 74.1 months at San Antonio 2019, and I'll be sharing that data with you. So the primary analysis revealed a three-year IDFS rate for the pertuzumab arm compared to the placebo arm shown here. Even though the study met its primary endpoint and was a positive trial, the results at this time point were somewhat disappointing given the small magnitude of benefit. There is light between those curves, but it's hard to see, so the clinical utility and cost question quickly became a topic of discussion. For higher risk patients, those with node positive or ER negative disease, there was more of a magnitude of benefit at that 3-year mark. The 6-year updated data is shown here, and now you see about a 3% difference, which was somewhat expected with longer follow-up. What was new at San Antonio was that the node positive what was not new at San Antonio was that the node positive cohort continued to derive clear benefit from the addition of pertuzumab shown here, and no benefit in the node negative patients. But what was new at San Antonio was that the treatment benefit of pertuzumab is also seen in the hormone receptor positive cohort at 6 years with longer follow-up. And again, in the ER negative cohort, this difference was already demonstrated. What I haven't shown you here is overall survival. With longer 6-year OS follow-up, there was with longer 6-year follow-up, an overall survival difference between patients who received pertuzumab versus placebo remained to be seen. A third interim OS analysis is planned in 2022. In terms of safety, there were no clear signs that adding pertuzumab increased toxicity in terms of cardiac safety. Primary endpoint of cardiac events was low in both arms, 0.7 and 0.3%. And now moving on to the Catherine trial. This trial has really transformed our approach to the treatment of early stage HER2 positive breast cancer and led to rapid approval of TDM1 in this setting globally. This trial allowed or included patients that had centrally confirmed HER2 positive early stage breast cancer and had undergone neoadjuvant therapy and then had residual disease in the tumor in breast or axillary nodes, and were randomized within 12 weeks to TDM1 versus trastuzumab. The primary endpoint was invasive disease-free survival. Here you see in terms of stratification factors, about 70% of patients were ER positive, ER negative was about 30%. There were patients that did receive trastuzumab and pertuzumab in the neoadjuvant setting, which is now currently the standard for patients that receive neoadjuvant treatment. About 18% in both arms did actually get dual antibody therapy. 80% had trastuzumab alone. And these were the really exciting data looking at the 3-year IDFS benefit to TDM1, almost 11%, and breaking it down by subgroups, all subgroups, even patients with very small amounts of residual disease got benefit from receiving TDM1 versus trastuzumab. In terms of toxicities, it's very frequent that we have patients that receive treatments that we perceive to be very well tolerated in the metastatic setting, not do as well in the adjuvant setting. And this is what we also saw in the Catherine trial, where 18% of patients had to discontinue TDM1 due to adverse events. And other toxicities are illustrated here and are quite consistent with what we already know to be related to TDM1, including platelet count decreases, AST, ALT, and some mild sensory neuropathy. So in terms of where we can still do better, it was disappointing to see that TDM1 did not seem to help with CNS mets. And in fact, numerically, as shown here, there were more patients diagnosed with the first IDFS event. There were more patients diagnosed with the first IDFS CNS event in patients getting TDM1. So why is this? Well, it may be related to this concept of competing risk. And this is something that we've also seen in the adjuvant trials. So the numerically higher rate of CNS recurrence as the first IDFS event in the TDM1 arm may be explained by competing risk. And the concept behind competing risk is that when you have a therapy that's very, very effective in eradicating systemic disease, you'll see a substantial reduction in the incidence of non-CNS recurrence as the first event, which leads to an increased likelihood of CNS recurrence as a first event and as the only site of recurrence. And if in fact this is true, by looking at the patterns of further incidence of CNS events, this should support this concept. And in fact, this data that is illustrated here in the table does just that. So as I mentioned, as the first IDFS event, there were higher incidence of CNS events in the TDM1 arm, but after that, as a subsequent event, there was only 1 versus 8 in the trastuzumab arm. Then there was a longer time to CNS recurrence in the TDM1 arm and a higher incidence of CNS recurrence as the only recurrence in the TDM1 arm. So the data is really consistent with this issue. It's not that TDM1 is predisposing to CNS metastases. It's just not as effective. So this really begs the question, what do we do for these patients that are very high risk? And given the approval and availability of neratinib in the extended adjuvant setting, I would say that we should perhaps be considering neratinib in this situation. And as they say, an ounce of prevention is worth a pound of cure. So let's put these data into context in terms of the trials that we've reviewed so far. This table is not meant to make any claims in terms of efficacy comparisons, but just to show you the patient populations that were enrolled in the various trials that we have reviewed so far. So how do we take this data and utilize it in the clinic? Here is a proposed strategy for managing patients with stage 1 to 3 HER2 positive early breast cancer. For these really small node negative tumors, perhaps a regimen like the APT trial with a taxane and trastuzumab or TH or TCH followed by a year of trastuzumab may be sufficient. For larger tumors, T1C and 0, we have to assess risk and patient preference, and some of these patients may in fact go to surgery first, followed by adjuvant treatment. For the larger tumors, clinical T2 or N1 disease, neoadjuvant treatment, as I showed you, is considered the standard of care. And for patients with residual disease, now TDM1 is considered the standard of care. We don't know, based on the ExteNet trial, those patients didn't receive TDM1 in the adjuvant setting as per the Catherine data, but I did show you the data that does not indicate a benefit in terms of CNS prophylaxis with the use of TDM1. So I would argue we should, in fact, still be considering neratinib in this setting. It's a discussion. And for patients with a PCR that are ER positive, we talked about the benefit that's emerged in that group with the use of pertuzumab. And this is also a discussion, trastuzumab plus or minus pertuzumab for the ER negative patients, HP would be appropriate. And then again, the consideration, especially in the ER positive patients for neratinib, knowing that even patients who achieve a PCR may still be at risk of relapse. Now let's move on to the metastatic setting and talk about incorporating new HER2 targeted agents. The first that was recently approved in the fall of 2019 was trastuzumab deruxtecan. This was based on this non-randomized phase 2 trial, DESTINY-Breast01. These patients were HER2 positive, centrally confirmed, and had all received prior TDM1. Those who had prior history of significant ILD were excluded, and part 1 was a dose finding part of the trial, and part 2 identified 5.4 milligrams per kilogram as the recommended phase 2 dose. Now these patients, in terms of patient characteristics, they had 91%, 92% had visceral disease. So these patients had a significant burden of disease, were quite heavily pretreated. The presence of ER positive disease was there in about 52%, and 24 patients, or 13%, had brain metastases that were stable and previously treated. 100% had received prior trastuzumab and TDM1. A good percentage had had pertuzumab as well, and other systemic therapy. These were patients that had received a lot of the treatments that we typically give for HER2 positive disease. The median number of prior cancer regimens was 5, but ranged all the way from 2 to 17. So a heavily pretreated population. And this is a very impressive waterfall plot that we all saw and caught everyone's eye. An overall response rate of 60.9%, which is really unprecedented in this group of heavily pretreated patients, with a clinical benefit rate, which includes partial response, complete response, and stable disease for at least 6 months, of 76%. These patients had a median duration of response of 14.8 months, and were quick to respond, with a median time to response of 1.6 months. Progression-free survival, 16.4 months, and overall survival has not been reached. Median PFS in those 24 patients with brain mets was 18.1 months. In terms of toxicities, the issue of ILD comes up quite frequently as a point of discussion about this agent, but the other toxicities that we're seeing are illustrated on this slide. It is important to note that in the trial, antiemetic prophylaxis, although not mandated, was received in about 70% of patients. And in my experience, without antiemetic prophylaxis, nausea can be a significant issue for this agent. In terms of other warnings and precautions for trastuzumab deruxtecan, a worrisome side effect of ILD pneumonitis should be recognized, and appropriate monitoring and management is necessary. So it's important to promptly investigate evidence of ILD for patients that have symptoms such as cough, dyspnea on exertion, shortness of breath. We have to evaluate these patients with suspected ILD by radiographic imaging, and consider consultation with the pulmonologist to help in terms of differential diagnosis. Interrupt the drug and initiate steroids if ILD or pneumonitis is suspected, and for asymptomatic ILD grade 1, consider steroids and holding the agent until recovery to grade 2. For symptomatic grade 2 or higher, promptly initiate steroid treatment, and actually you have to permanently discontinue the drug in this setting. Now moving on to the NALA trial, neratinib and capecitabine was approved in an expanded label for neratinib based on this trial in the metastatic setting, where neratinib capecitabine versus lapatinib capecitabine was evaluated in metastatic patients who had had greater than or equal to 2 prior lines of HER2-directed therapy. This was a open label randomized phase 3 trial of patients that had previously treated disease. Asymptomatic stable brain mets were allowed, and again they were randomized to neratinib cape versus lapatinib cape, and the co-primary endpoints were OS and PFS. In terms of baseline characteristics, about 60% of patients were ER positive, a good percentage, 80% had visceral disease, and you see the breakdown in terms of the prior HER2 targeted therapies that they had received. So the trial, the design called for performing a pre-specified restricted means analysis if the assumption of constant proportional hazards was not shown. And you see the curve starting to separate at 6 months and an improvement in PFS of about 2 months associated with the use of neratinib. You see almost a doubling of progression-free survival from 15 to 29% and even out to 18 to 21 months, the curves remain separated. In terms of time to intervention for CNS metastasis, predominantly radiation therapy as the intervention, which is associated with significant side effects when given repeatedly. You did see the time to intervention being longer for neratinib and capecitabine versus lapatinib and capecitabine. And again, safety, diarrhea, grade 3 or 4, 24%. The median duration of treatment, however, was numerically longer with neratinib versus lapatinib, and discontinuation due to treatment emergent AEs in the neratinib arm was 10.9%, and lapatinib was actually higher at 14.5%. No grade 4 diarrhea was observed. And then moving on to the recently approved tucatinib, this highly selective TKI, which is highly selective to HER2 and has less EGR-associated toxicity. This drug, we know based on phase 1 data, has CNS penetration and is well tolerated and active in combinations, as shown here. The HER2-CLIMB study was a randomized double-blind placebo-controlled active comparator phase 2 trial. As shown here, patients with HER2 positive metastatic disease who had all received prior trastuzumab, pertuzumab, and TDM1. Even patients with brain mets, both active and stable, were allowed on. We'll talk a little bit more about this when we look at patient characteristics. These patients were randomized to tucatinib, trastuzumab, and capecitabine versus placebo, trastuzumab, and capecitabine. Primary endpoint was PFS, and the secondary endpoints are shown. So here's what's really unique about this trial. I'll draw your attention to the red box, which breaks down the subgroups of patients with brain metastases. And the approximately 60% of patients that had brain metastases within that 48% who out of the entire group that had brain mets were actually treated and stable. And it's not unusual for these patients to be allowed on a clinical trial, but what is unusual are the patients that had untreated or treated and progressing brain metastases. They accounted for another about 40% of the entire brain met group. Those patients are traditionally not permitted on trial. Here you see the primary endpoint of progression-free survival, about a 2-month improvement in progression-free survival with the use of tucatinib and trastuzumab capecitabine relative to placebo and the same combination. This hazard ratio of 0.54 was associated with the 46% reduction in the risk of disease progression. And the subgroup analyses with regards to progression-free survival demonstrated that regardless of which subgroup you look at here, there was an improvement with that favored tucatinib versus placebo. And these are the really impressive data that show this overall survival benefit of 4.5 months, hazard ratio of 0.66, 34% reduction in the risk of death. Again, subgroup analyses showed a benefit with regards to all subgroups favoring tucatinib. In the patients specifically who had brain metastases, progression-free survival was also demonstrated to be longer in the tucatinib group. And these are the data with regards to progression systemically as well as CNS. I'll show you in the next couple slides some of the more updated CNS progression data that was presented recently at ASCO. In terms of adverse events greater than 20% in the tucatinib arm, you see the incidence of diarrhea, PPE syndrome, nausea, fatigue shown here. Again, overall, this agent is fairly well tolerated with rates of diarrhea that are quite manageable. So as I alluded to, there was a subgroup analysis of patients with brain mets in HER2 Climb that was presented at ASCO this year. It's important to remember that these patients were included and they had a brain MRI at baseline. The ones that had brain metastases had to not require immediate local therapy. They could have received local therapy during screening and then eligible after the washout. And these patients were followed with subsequent brain MRIs. So this slide nicely illustrates the breakdown of the 291 patients that had brain mets. 117 were treated and stable. They were previously treated and they had no progression at baseline. And then the other 174 patients that were considered active and completely untreated, but not requiring immediate local therapy, so tumors that were small without edema, or treated and progressing, previously treated but progression of existing lesions, new lesions, or untreated at baseline. And here we look at the CNS progression-free survival, meaning the progression in the brain specifically. And you see a hazard ratio that's really, really striking of 0.32. The risk of CNS progression or death was reduced by 68% in patients with brain metastases. You see the 40.2% CNS PFS at 1 year in patients that received tucatinib versus 0% CNS progression free at 12 months if patients were randomized to placebo. And you see the difference between the median CNS PFS 4.2 versus 9.9 months. So this is really striking data and represents a dramatic improvement in options for patients with brain metastases. The CNS subgroups were further broken down, and again, this table is a bit complicated, but I'll draw your attention to the column, the first column that illustrates the brain metastases summary data, and then the stable and active brain mets are broken down in terms of median PFS, CNS PFS, and OS. Again, a survival benefit and CNS PFS as well as median PFS, all favoring the use of tucatinib. So here we have a nice summary slide that again illustrates some of the efficacy endpoints in the various studies that we've gone through, understanding that these trials included slightly different populations of patients, and again, not meant to make any claims with regards to efficacy comparisons. Now we have emerging anti-HER2 therapies that have gained FDA approval, and this is a nice timeline that shows you when those approvals were gained. Based on the NALA phase 3 trial, we now have neratinib and capecitabine as an option, and for patients who have received more than 2 prior lines of anti-HER2 based therapy in the metastatic setting, we now have trastuzumab and trastuzumab deruxtecan for these patients, and for patients that have received 1 or more prior lines of anti-HER2 based therapy in the metastatic patients, including those with active brain mets and stable brain mets, as well as those without brain mets. The HER2 Climb data represents an important improvement in terms of options for these patients with the use of tucatinib. So these data are really encouraging, and there are some considerations for how to sequence these therapies, but I would say that this is a good problem to have for our patients as we now have expanding options. Let's close with a few discussion points regarding future directions. I'll call to your attention the ongoing NRG-B004 trial, which may change how we treat first-line HER2-positive metastatic patients. The Cleopatra regimen of a taxane, trastuzumab, and pertuzumab has become standard in that setting. This trial looks to determine the addition of atezolizumab, the checkpoint inhibitor, to a regimen of paclitaxel, pertuzumab, and trastuzumab to see if this combination will improve progression-free survival relative to paclitaxel, trastuzumab, and pertuzumab, which again is the standard. And this is an important ongoing trial. Tucatinib plus, or the HER2-CLIMB-2 trial is also ongoing, looking at tucatinib or placebo plus T-DM1 in unresectable HER2-positive patients. So here, patients that are metastatic and have been previously treated with a trastuzumab and a taxane. Previous pertuzumab is permitted but not required. Untreated brain mets not requiring immediate local therapy are allowed on, again, stable brain mets as well, randomizing to tucatinib in combination with T-DM1 versus placebo and T-DM1. So this is also another ongoing important study. The DESTINY-Breast2 trial looks to compare trastuzumab deruxtecan to investigators' choice of trastuzumab and capecitabine or lapatinib and capecitabine. The design is shown here. Again, another study that will hopefully help us inform sequencing. And the DESTINY-Breast03 trial looks to compare trastuzumab deruxtecan versus T-DM1, which has become a standard of second-line therapy, directly comparing those two in patients with metastatic disease who have received trastuzumab and a taxane. CNS mets here are allowed. And then finally, the concept of using trastuzumab deruxtecan in these patients that have HER2 low, meaning IHC 1+ or 2+, but FISH negative. This strategy is being investigated in the DESTINY-Breast04 trial, which is looking at trastuzumab deruxtecan versus chemotherapy of physician's choice, which can include capecitabine, eribulin, gemcitabine, or a taxane. So I think that we have expanding options and hopefully future information from ongoing trials that will be available that will inform our decision-making as we've continued to make significant progress for patients with HER2-positive metastatic breast cancer. I look forward to taking your questions in the chat, and thank you for your time.